I'm about to destroy 8 myths that your doctor told you about atrial fibrillation. Myths that are putting you at stroke risk right now while you think you're protected. I'm U.S. Dr. Sarah Senior's Health Tips, and after 2 decades as a cardiac surgeon, I've seen what happens when people believe these lies. They end up in my operating room, or worse, they end up in the morgue. Because atrial fibrillation doesn't give you a second chance, it gives you a stroke. And that stroke doesn't just weaken you, it destroys you. Your speech, your memory, your ability to swallow, your independence gone. In the time it takes for a blood clot the size of a grain of rice to travel from your heart to your brain, John took a baby aspirin every morning for 10 years. His doctor told him it would protect him from a stroke. He thought he was safe. He woke up one Tuesday morning and his right side wouldn't move. His face was drooping. His speech was slurred. His wife called 911. By the time he got to the hospital, half his brain was dead. The stroke had destroyed his left middle cerebral artery. We couldn't save that tissue. John survived, but he'll never walk normally again, never speak clearly again, never be independent again. All because he believed the first myth, the aspirin myth. Here's what your doctor told you. Take a baby aspirin every day. It thins your blood. It prevents clots. It protects you from stroke. That's true if you have coronary artery disease, if you have plaque in your arteries, if you're at risk for a heart attack, but it's completely false if you have atrial fibrillation because AFib doesn't cause the same kind of clots. Understanding this difference could save your life. So, pay attention. There are 2 types of blood clots, arterial clots and stasis clots. Arterial clots form when plaque ruptures. The plaque breaks open, your body tries to patch it. Platelets rush to the site. They stick together. They form a clot. This is a platelet clot. It's made of cells stuck together like bricks. Aspirin works on platelets. It makes them slippery. They can't stick together as easily. So aspirin prevents arterial clots. It prevents heart attacks. But AFib doesn't cause arterial clots. AFib causes stasis clots. These are completely different. Stasis means stillness, non-movement. When blood sits still, it clots. Not because of platelets, because of a protein called fibrin. Think of fibrin as a spider web. When blood stops moving, fibrin threads form. They weave together. They trap red blood cells. They create a jelly-like clot. This is a fibrin clot. It's not made of platelets. It's made of protein strands. And aspirin does nothing to fibrin. Nothing. Aspirin is a platelet inhibitor. Fibrin clots don't involve platelets, so aspirin can't prevent them. Here's the analogy. Imagine 2 types of structures. One is made of bricks stacked together. That's a platelet clot. If you make the bricks slippery with aspirin, they can't stack. The structure falls apart. But now imagine a structure made of spider webs. That's a fibrin clot. Making the bricks slippery doesn't affect the spider web at all. It's the wrong tool. That's what you're doing when you take aspirin for AFib. You're using the wrong tool. You're not preventing the clot that actually forms. But here's the worst part. Aspirin still causes bleeding. It makes your platelets slippery, so if you cut yourself, if you have a nosebleed, if you develop a stomach ulcer, you bleed more. You have all the bleeding risk of a blood thinner with 0 stroke protection. Using aspirin for AFib is like trying to put out a forest fire with a water pistol. You feel like you're doing something, but you're accomplishing nothing. And while you think you're protected, the real clot is forming. Where does this clot form? In a structure called the left atrial appendage. This is a small pouch that hangs off your left atrium. It looks like a windsock. In normal rhythm, your atrium contracts. It squeezes. Blood flows through the appendage in and out. It stays fresh. But in AIB, your atrium doesn't contract. It quivers. It fibrillates. The muscle just vibrates uselessly. No organized contraction. No squeeze. No flow. Blood sits in the appendage, stagnant, still, and stagnant blood clots. The fibrin threads start forming. They weave together. Within hours, you have a soft jelly clot. Within days, it hardens, and then one day, for reasons we don't fully understand, that clot breaks off. It shoots out of your heart into your bloodstream, up your carotid artery, into your brain, and wherever it lodges, that part of your brain dies instantly. The stroke happens in seconds. John's clot was small, maybe 5 millinin, but it blocked his middle cerebral artery, the artery that feeds the motor cortex, the part of your brain that controls movement. Half his body stopped working, all because he thought aspirin was protecting him. It wasn't. The mechanism behind this is called Vow's triad. This is a concept every surgeon knows, but most patients have never heard of. Virchow's triad describes the 3 conditions that lead to clot formation. First, stasis, blood that doesn't move. Second, endothelial injury, damage to the lining of blood vessels. Third, hypercoagulability, blood that clots too easily. In AFib, you have all 3. Stasis because your atrium doesn't contract. Endothelial injury, because the turbulent blood flow in your fibrillating atrium damages the lining. Hypercoagulability, because chronic AFib activates your clotting cascade. You're a clotting machine. And aspirin addresses none of these factors. It doesn't restore atrial contraction. It doesn't heal endothelial damage. It doesn't affect the clotting cascade. It works on platelets. And AFib clots aren't platelet clots. They're fibrin clots. If you have AFib, aspirin is useless. You need a real anticoagulant warfarin or one of the newer drugs like apixaban, rivaroxaban, dagatran, edoxaban. These drugs work on the clotting cascade. They prevent fibrin formation. They stop stasis clots. They actually protect you from stroke. But your doctor might not have prescribed them. Why? Because of myths we'll address. But understand this clearly. Aspirin for AFib is medical malpractice. It's giving you false reassurance while leaving you completely vulnerable. John learned this the hard way. His doctor prescribed aspirin because John was 68 and low risk. He had no other medical problems, no hypertension, no diabetes, no heart failure. His CHADS 2 VASC score was only 1 point for age. The guidelines at the time suggested aspirin was acceptable for low-risk patients. Those guidelines have changed. We now know aspirin doesn't work, but John's doctor was practicing old medicine, and John paid the price. His stroke was massive, left middle cerebral artery occlusion. When the clot lodged there, it cut off blood flow to a huge territory of his brain, the motor strip, the language centers, the sensory cortex. Within minutes, those neurons were dying. By the time he reached the hospital, the damage was done. We tried thrombolysis, TPA, clot-busting medication. It didn't work. The clot was too big, too organized, too mature. It had been sitting in his left atrial appendage for days, maybe weeks. It had hardened. Fibrin strands had cross-line. Red blood cells were trapped in the mesh. It was like concrete. TPA couldn't dissolve it. We tried mechanical thoracotomy, a catheter with a retrieval device. We went up through his femoral artery, up the aorta, into his carotid, into his brain. We tried to grab the clot and pull it out. We got pieces, but not all of it. Some fragments broke off and lodged in smaller vessels downstream. More brain tissue died. John survived the procedure, but the damage was catastrophic. His right arm and leg were paralyzed. He couldn't speak. He could understand language. He knew what he wanted to say, but the words wouldn't come. Expressive aphasia, the most frustrating form of stroke disability. Your mind is intact, but you can't communicate. He spent 3 months in acute rehabilitation, learning to walk with a walker, learning to use his left hand for everything because his right hand was useless, learning to communicate with gestures and a speech device. He never went home. He went to a nursing home. His wife visited every day, but he wasn't the same man. The stroke had stolen him, his personality, his independence, his dignity, all because someone told him aspirin would protect him. It didn't. It never could have, because aspirin doesn't prevent fibrin clots, and fibrin clots are what AFib produces. Now, the second myth, the silent myth. Here's what people think. If I can't feel my heart racing, I'm not in a palpitations. If my heart feels normal, I'm fine. Wrong. Silent AFib is deadlier than symptomatic AIB, because when you feel your heart racing, when you feel the palpitations, you go to the doctor, you get diagnosed, you get treated, you get anticoagulated, you're protected. But when you don't feel anything, you don't seek treatment. You walk around for months, maybe years, with your atrium quivering, with blood pooling in your left atrial appendage, with clots forming, and you have no idea. Sarah, 72, felt fine. No palpitations, no symptoms. She went for a routine physical. Her doctor did an EKG, atrial fibrillation. Sarah was shocked. She felt completely normal. How could her heart be in an abnormal rhythm if she felt fine? Her doctor explained that about 30% of AFib is asymptomatic, silent. You don't feel it because your ventricles, the bottom chambers, are still pumping normally. The rate might be controlled. You have good blood pressure, good perfusion. You feel fine, but your atria, the top chambers are quivering, blood is pooling, clots are forming. The mechanism of silent AFib is fascinating and terrifying. Your ventricles determine how you feel. If your ventricles are pumping 60-70 times per minute, if they're filling adequately, if they're ejecting blood properly, you feel normal. Your blood pressure is stable. Your organs are perfused. You have no symptoms, but your atria can be fibrillating wildly. 400, 500, 600 electrical impulses per minute. Chaotic, disorganized. The atrial muscle quivering like a bag of worms. No effective contraction. And because your AV node is blocking most of those signals, only letting 60 or 70 through to your ventricles, you don't feel the rapid rate. You don't feel palpitations, you feel nothing. But that doesn't mean nothing is happening. In your left atrial appendage, blood is sitting still. The appendage is shaped like a windsock, narrow neck, wide body, multiple lows. In normal sinus rhythm, when your atrium contracts forcefully, blood shoots into the appendage and immediately gets ejected back out. The entire appendage empties with each contraction. Fresh blood in, stale blood out, no stasis. But in AIB, there's no contraction. Blood drifts into the appendage and just sits there. And blood that sits still for more than a few hours undergoes a process called stasis thrombosis. The red blood cells settle to the bottom like sediment. The plasma separates. Clotting factors become concentrated. Fibrin strands start forming. Thrombin is generated. The clotting cascade activates. Within 24 to 48 hours, you have a visible clot. It starts as soft, gelatinous material. Echocardiographers call it spontaneous echo contrast. It looks like smoke swirling in the atrium. This smoke is a precursor to clot formation. It's red blood cells aggregating in slow-moving blood. And once you see smoke, you know a clot is coming. Within days, the smoke solidifies. The fibrin mesh tightens. The clot becomes organized. Laminated layers form. It adheres to the wall of the appendage. And then it sits there, growing, maturing, waiting. Sarah's doctor immediately started her on apixaban, an anticoagulant. He explained that even though she felt fine, her stroke risk was high. Her CHADS VASC score was 3. 1 point for being female, 1 point for age 72, 1 point for hypertension. 3 points means high risk, 5 to 7% annual stroke risk without anticoagulation. Apixaban would reduce that risk by 60 to 70%. Sarah took it religiously, every dose, twice a day. She didn't want a stroke. 2 months later, she woke up with her left side tingling, numb. She couldn't lift her left arm. She called 911. At the hospital, they did a CT scan. No bleed. They did an MRI. Small acute infar in the right frontal lobe. A stroke. Small, mild symptoms, but a stroke nonetheless. How? She was on anticoagulation. She was doing everything right. They did a transesophageal echocardiogram. That's an ultrasound probe passed down the esophagus to get a close look at the heart. They saw it. A small clot in her left atrial appendage. Despite being on apixaban, despite therapeutic anticoagulation, the clot was there. It had formed before she started treatment. It had been sitting there for weeks, slowly maturing, and a small piece had broken off, emblased, traveled to her brain, caused the stroke. The stroke was mild. Her symptoms resolved within 48 hours. She was lucky, but she almost wasn't. If that clot had been bigger, if it had broken off completely, if it had lodged in her middle cerebral artery instead of a small frontal branch, she would have been devastated, paralyzed, aphasic, dead. All because her AIB was silent. She never knew she had it until a routine EKG caught it by chance, and by then, the clot was already forming. This is why screening matters. If you're over 65, you should have an EKG annually at minimum. If you have risk factors, hypertension, diabetes, obesity, sleep apnea, you should have more frequent monitoring. Some experts recommend wearable devices. Continuous monitoring because catching AFib early before clots form is the key to preventing stroke. Silent AFib is a ticking time bomb. You don't hear it, you don't feel it, but it's destroying your left atrial appendage, turning it into a clot factory. And the first symptom might be a stroke. By then it's too late. The damage is done. Don't wait for symptoms. Get screened. Get monitored. And if you're diagnosed, get treated immediately. The third myth, the rate control myth. Your doctor gave you a beta blocker, amitriptyl, atenyl, or a calcium channel blocker, dilyazam, verapamil. Your heart rate slowed down. You feel better. The palpitations stopped. Your doctor says the problem is controlled. You think you're safe. You're not. Rate control is not rhythm control, and the difference could cost you your life. Your heart has two properties that matter in AFib, rate and rhythm. Rate is how fast your ventricles beat. Rhythm is the pattern of electrical activity in your atria. In AFib, your atria fire chaotically, 400 to 600 impulses per minute. If all those impulses reached your ventricles, your heart would beat 400 times per minute. You die within minutes. Ventricular fibrillation, cardiac arrest. But your AV node protects you. It's a gatekeeper. It filters the signals coming from your atria. It only lets some through, maybe 120, maybe 150. Your ventricles beat rapidly, but not lethally. You feel this as palpitations, your heart racing, pounding. You can't catch your breath. You feel weak, dizzy, fatigued. This is symptomatic rapid AIB, and it feels terrible. So, your doctor gives you a medication to slow your heart rate, a beta blocker or calcium channel blocker. These drugs work by slowing conduction through the AV node. They make the gatekeeper more selective. Now only 70 or 80 impulses per minute get through to your ventricles. Your heart rate normalizes. You feel better. The palpitations stop. You can breathe. You have energy. The symptoms are gone. Your doctor checks your pulse. 72 beats per minute. Perfect. He says you're controlled. But here's what he didn't tell you. Your atria are still fibrillating. They're still firing 400 times per minute, chaotically, disorganized, no effective contraction. Blood is still pooling in your left atrial appendage. Clots are still forming. The stroke risk hasn't changed at all, not even a little bit, because stroke risk depends on rhythm, not rate. As long as your atria are fibrillating, as long as there's no organized atrial contraction, blood sits still, stasis occurs, clots form. It doesn't matter if your ventricular rate is 150 or 70. The atrium doesn't know. The atrium doesn't care. It's quivering regardless. The appendage is stagnant regardless. The clot is forming regardless. Rate control fixes your symptoms. It makes you feel better, but it does nothing for the disease, nothing for the pathology, nothing for the stroke risk. This is why rate control without anticoagulation is negligence. You've taken away the patient's symptoms, the warning signs that something is wrong, but left them completely vulnerable to stroke. Robert was 68. He developed AFib after a viral illness. His heart rate was 140. He felt terrible, palpitations, shortness of breath, weakness. He went to the emergency room. They gave him mitoprolol. His heart rate dropped to 75. He felt immediately better. The palpitations stopped. He could breathe. He felt normal. The ER doctor discharged him, told him to follow up with his primary care doctor, gave him a prescription for Medipol, told him to take it twice a day. Robert asked, "Do I need a blood thinner?" The ER doctor said, "Let's see if the AIB persists. Sometimes it's just a one-time thing after a viral illness. Your primary care doctor will decide." Robert went home. He took his metoprolol. He felt fine. No symptoms. He assumed the problem was solved. He didn't follow up with his primary care doctor for 2 months. Why would he? He felt fine. 6 months later, Robert woke up and couldn't move his left side. His wife called 911, massive stroke, right MCA territory. The clot was huge. We tried thrombectomy. We couldn't retrieve it. It was too organized, too adherent. Robert died 3 days later from brain herniation. The stroke was so massive that his brain swelled. It had nowhere to expand inside his skull. The pressure built. His brainstem herniated through the foramen magnum. He stopped breathing. We couldn't save him. He was 68 years old. He died from a preventable stroke because someone told him rate control was enough. It wasn't. His atria were fibrillating for 6 months. Blood was pooling for 6 months. The clot was growing for 6 months. And when it finally broke off, it killed him. Rate control plus anticoagulation. That's the minimum standard of care for AFib. You cannot do one without the other. If you're going to leave someone in AFib, if you're not going to attempt rhythm control, you must anticoagulate them. There is no exception to this rule. Unless they have active bleeding, unless they've had a recent brain hemorrhage, unless they're dying from something else and stroke prevention is irrelevant, those are the only exceptions. Everything else is an indication for anticoagulation. But doctors don't always prescribe it. Sometimes they forget. Sometimes they're worried about bleeding risk. Sometimes they think the patient is too old, too frail, too likely to fall. These are myths we'll address. But understand this. Rate control without anticoagulation is abandonment. It's treating the symptom and ignoring the disease. It's making the patient feel better while leaving them to die from a stroke. Don't accept it. If your doctor gives you rate control medication but doesn't prescribe anticoagulation, ask why. Demand a reason. And if that reason is anything other than active bleeding or recent hemorrhage, demand a second opinion. Your life depends on it. The fourth myth, the fall risk myth, this one makes me angrier than any other because it's based on fear, not science, and it kills people, kills them. Elderly patients are diagnosed with AFib. The doctor recommends anticoagulation, Warfarin, or one of the newer agents. The patient or the family says, "But what if they fall? Won't they bleed into their brain? Isn't that more dangerous than a stroke?" And some doctors, trying to avoid conflict, trying to seem reasonable, say, "You're right, the fall risk is concerning. Let's hold off on anticoagulation for now. We'll monitor the situation." That decision is a death sentence. Here's why. The risk of a major bleed on anticoagulation is approximately 2 to 3% per year. The risk of an intracranial hemorrhage, specifically a brain bleed, is about 0.5 to 1% per year. That's low, very low. Now, compare that to stroke risk. Untreated AFib in an elderly patient with other risk factors has a 5 to 10% annual stroke risk. Some patients, those with high CHADS2 VASC scores, have even higher risk, 15% per year, 1 in 7 chance of stroke every single year. Just comparing those numbers, stroke risk is much higher than bleeding risk. But let's go deeper, because the real question isn't which risk is higher, it's which outcome is worse, a bleed or a stroke. A bleed, even a brain bleed, can often be managed. You go to the emergency room, they give you reversal agents. For Warfarin, they give vitamin K and fresh frozen plasma, or prothroin complex concentrate. For the newer anticoagulants, there are specific reversal agents. Idarucimab for dabigatran and Dexet alpha for ixaban and rivaroxaban. They reverse the anticoagulation. They stop the bleeding. You might need surgery, a craniotomy to evacuate a hematoma, but often you survive. You recover. Many patients who have intraanal hemorrhage on anticoagulation walk out of the hospital neurologically intact. Now, a stroke. An AIB stroke is not a small stroke. AFib clots are large. They're organized, they're dense, they block major arteries. Middle cerebral artery, basilar artery, posterior cerebral artery. When these arteries are blocked, massive territories of brain tissue die. The stroke is devastating. Survival rates are lower than for hemorrhage. And even if you survive, the disability is profound. Paralysis, aphasia, cognitive impairment, inability to swallow. You end up in a nursing home dependent on others for every basic need. Bathing, dressing, eating, toileting. Your dignity is gone. Your independence is gone. Your life as you knew it is over. Which is worse? A bleed that can be reversed and often leaves you intact, or a stroke that destroys your brain and leaves you permanently disabled? The answer is obvious, but here's the data that should end this argument forever. Researchers asked this exact question. How many times would an elderly person on anticoagulation have to fall in 1 year for the risk of intracranial hemorrhage to outweigh the risk of stroke from untreated AFib? They did the math. They calculated the probability of intracranial hemorrhage from a fall while on anticoagulation. They compared it to the annual stroke risk of untreated AFib. The result? 295 falls per year. That's the break-even point. You'd have to fall 295 times in 1 year, almost once every single day, for the bleeding risk to equal the stroke risk. Think about that. If you're falling once a day, every day, anticoagulation is the least of your problems. You need a walker. You need physical therapy. You need assisted living. You need a completely different level of care. But for a normal elderly person who falls once or twice a year, the stroke risk is orders of magnitude higher than the bleeding risk. Anticoagulation is absolutely the right choice. But doctors are afraid. Families are afraid. And that fear, that irrational fear, leads to undertreatment. It leads to preventable strokes. It leads to death. Dorothy, 81, had AFib. She had hypertension. She had diabetes. Her CHADS VASC score was 6. Her annual stroke risk without anticoagulation was approximately 9%, nearly 1 in 10 chance every year. Her cardiologist recommended apixaban. Dorothy's daughter, a nurse, said absolutely not. She said, "My mother is frail. She uses a cane. She's had 2 falls in the past year. If she falls on a blood thinner, she could bleed to death." The cardiologist tried to explain the data, the 295 falls calculation, the much higher stroke risk, but the daughter wouldn't budge. She was terrified of bleeding. She'd seen patients bleed on Warren during her nursing career. She couldn't get past that fear. The cardiologist didn't push. He documented the discussion. He wrote that the family declined anticoagulation against medical advice. He told them to follow up in 3 months. Dorothy went home. No anticoagulation. 4 months later, she collapsed at home. Her daughter found her on the floor unresponsive. Right-sided hemiplegia, global aphasia, massive left MCA stroke. The paramedics brought her to the hospital. CT scan showed a huge infarct. More than a third of her left hemisphere was already dead. There was nothing we could do. Dorothy never woke up. She died 2 days later when her family withdrew life support. Her daughter was devastated. She came to me crying. She said, "I killed my mother. I was so afraid of bleeding that I let her have a stroke." I didn't disagree. She made the wrong choice. But I understood why. The fear of bleeding is visceral. It's tangible. You can picture it. Blood, trauma, death. But stroke risk is abstract. A percentage, a statistic, until it happens. And then it's too late. If you have AIB, if your doctor recommends anticoagulation, take it. Don't let fear make the decision. Let data make the decision. And the data is clear. Anticoagulation saves lives. Bleeding risk is manageable. Stroke risk is catastrophic. Take the medication. Protect your brain. And if you're worried about falls, address the fall risk. Get a cane. Get a walker. Install grab bars in your bathroom. Improve lighting in your home. Do balance exercises. Strengthen your legs. Work with a physical therapist, remove tripping hazards, but don't refuse anticoagulation. The stroke risk is real, the stroke outcome is devastating, and the bleeding risk, while real, is far lower and far more manageable. Before we continue, I want you to do something right now. Subscribe to this channel, hit that button, because what I'm about to share in the next myths could completely change how you think about your AIB treatment. If you're not subscribed, you might lose this video. You'll never find this information again, and you need it. Subscribe now. The 5th myth, the I'm cured myth. You had an ablation or a cardioversion. Your heart rhythm is normal now. Sinus rhythm. Your doctor checks your EKG. Perfect P waves, regular QRS complexes, normal rhythm. You feel great. No more palpitations, no more shortness of breath. You're back to your old self. You ask your doctor, "Can I stop my blood thinner now? I'm in normal rhythm. I don't need it anymore, right?" Some doctors say yes. They tell you to stop after 3 months of normal rhythm. Some say 6 months. They're all wrong. Here's why. AFib leaves scars, not scars you can see, electrical scars. Fibrosis in your atrial tissue. This fibrosis is the substrate for AFib. It's the reason AFib happened in the first place. Your atrial tissue has undergone remodeling. The muscle fibers have been replaced by scar tissue. This scar tissue doesn't conduct electricity properly. It creates areas of slow conduction, areas of electrical block. And these areas create re-entry circuits, electrical signals that loop back on themselves, spin in circles, create chaos. This is what causes AFib. And when you do an ablation, you're not removing the substrate, you're adding to it. An ablation works by burning additional scar tissue into your heart. You're creating strategic lines of scar that interrupt the re-entry circuits. You're isolating the pulmonary veins, the most common source of triggers. You're creating electrical barriers that prevent the chaotic signals from spreading. The ablation works. Your rhythm normalizes. The AIB stops, but the substrate is still there. The original fibrosis that caused the AFib, plus the new scars from the ablation. And fibrosis is forever. Scar tissue doesn't heal. It doesn't go away. It's permanent. This means AFib can recur. The substrate is still there. New triggers can emerge. New re-entry circuits can form around the ablation scars. Studies show that 30 to 50% of patients have recurrent AFib within 1 year of ablation. Some recurrences happen immediately within days or weeks. These are usually from acute inflammation at the ablation sites. The scar tissue is still forming. Electrical conduction is unstable. AFib returns. Many of these patients need a second ablation, but some recurrences happen months or years later, after the ablation has healed. After you've been in normal rhythm for 6 months, a year, 2 years, you think you're cured. You've stopped your anticoagulation, and then one day the AFib comes back. Sometimes you feel it. Palpitations return. You go to the doctor, they catch it. They restart your anticoagulation. Crisis averted, but sometimes you don't feel it. Silent recurrence. Your heart goes back into AFib and you have no idea. You're not monitoring, you stopped your blood thinner months ago, you think you're cured and clots start forming again in your left atrial appendage, silently growing, maturing, and then one day you have a stroke. Out of nowhere. You thought you were cured. You weren't. The substrate was still there, the AFib came back. And because you weren't protected, the stroke happened. This is why current guidelines recommend continuing anticoagulation indefinitely after ablation if you have stroke risk factors. If your CHADS 2-VASC score is 2 or higher, you stay on anticoagulation, even if your rhythm is normal, even if you haven't had AFib in years, because the risk of silent recurrence is too high, and the consequence of unprotected recurrence is stroke. Michael, 70, had persistent AFib for 3 years. It was symptomatic. Palpitations, fatigue, shortness of breath. His quality of life was terrible. He tried multiple medications, none worked. His electrophysiologist recommended an ablation. Michael agreed. The procedure went well. Pulmonary vein isolation, linear ablations in the left atrium. His rhythm converted to normal immediately. He felt amazing, better than he had in years. His doctor told him to stay on apixaban for 6 months. Then they'd reevaluate. If he stayed in normal rhythm, they could consider stopping it. 6 months passed. Michael felt great. No palpitations, no symptoms. His doctor did an EKG, normal sinus rhythm, a Holter monitor, 24 hours of continuous monitoring, no AIB. Perfect. His doctor said, "You can stop the apixaban. You're cured." Michael was thrilled. He hated taking medication. He stopped the apixaban immediately. He felt free. 8 months later, Michael collapsed while grocery shopping. Bystanders called 911. He was unresponsive. Paramedics intubated him. They brought him to the hospital. CT scan showed a massive stroke, left MCA territory, hemorrhagic transformation. The initial ischemic stroke had bled into itself. His brain was swelling. We did an emergency decompressive craniectomy. We removed part of his skull to let his brain expand. It didn't help. The damage was too severe. Michael died 4 days later. In the ICU before he died, we checked his rhythm. Atrial fibrillation. His AFib had recurred silently, probably weeks or months earlier. He never felt it, never knew. Clots formed, one embolized, stroke, death. If he'd stayed on apixaban, he'd be alive. The clot wouldn't have formed, or if it did, it would have been smaller, less organized. The stroke might have been minor instead of fatal, but he stopped his anticoagulation because someone told him he was cured. He wasn't. Fibrosis is forever. The substrate remains. AFib can always come back, and when it does, if you're not protected, you're at risk. This is why I tell all my patients, if you've had AFib, you stay on anticoagulation unless there's a compelling reason to stop. Active bleeding, recent hemorrhagic stroke, terminal illness, those are reasons to stop. Being in normal rhythm is not. The risk of recurrence is too high. The consequence of unprotected recurrence is too severe. Don't stop your anticoagulation just because you feel good. AFib is a chronic disease. It requires chronic treatment. Accept that. Embrace that. Stay on your medication. Protect your brain. The sixth myth, the watch myth. You bought an Apple Watch or a Fitbit or a Cardia device. It has an ECG feature. It monitors your heart rhythm. It alerts you if it detects AIB. When your readings are normal, you feel reassured. You think you're being monitored. You think if AFib starts, the watch will catch it. You're protected. You're not. Wearable devices are incredible tools. They've revolutionized AFib detection. They've identified thousands of cases that would have gone undiagnosed for years. They've saved lives. I'm not against them. I recommend them. But they're not perfect. They have limitations. And if you don't understand those limitations, you'll have false reassurance. You'll think you're protected when you're not. The biggest limitation is that wearables only detect AIB when you're wearing them and when conditions are right. If your watch is charging, it's not monitoring you. If you take it off to shower, to sleep, to swim, you're not being monitored. If you're moving around, if the watch shifts on your wrist, if the contact isn't perfect, the reading might be inaccurate or unreadable. The algorithm might not be able to determine your rhythm. And most importantly, wearables miss short episodes. Paroxysmal AFib, AFib that comes and goes. You might be in normal rhythm 23 hours a day, but for 1 hour while you're sleeping, while your watch is on the nightstand charging, your heart goes into AFib. The watch never sees it. You never know about it, but that 1 hour is enough. Blood sits still in your left atrial appendage for 1 hour. Fibrin threads start forming. The clot begins, and even though you convert back to normal rhythm, even though blood flow resumes, that early clot doesn't dissolve. It stays. It continues to grow during the next episode and the next, and eventually it embolizes. Stroke. And you never knew you had a watch, never caught it. Helen, 74, was vigilant about her health. She wore an Apple Watch religiously. She checked her ECG multiple times a day. Every reading was normal. Sinus rhythm. She felt safe. She thought if she ever developed AFib, the watch would alert her immediately. One morning, she woke up unable to move her left side. Her face was drooping. She tried to call for help, but her speech was slurred. Her husband called 911. Stroke, left-sided weakness, facial droop, dysarthria. At the hospital, they put her on continuous cardiac monitoring, telemetry. Over the next 48 hours, they caught 3 episodes of AFib, each lasting 20 to 40 minutes, all happening between 2 and 4 a.m., while she was asleep while her watch was charging. Her watch had never detected a single episode, because every episode happened while the watch wasn't on her wrist. But her heart had been going in and out of AFib for weeks, maybe months. Short bursts, paroxysmal, enough to form clots. Not enough to cause symptoms, not enough for the watch to catch. The stroke was the first manifestation, and by then the damage was done. Wearables are screening tools. They're not diagnostic. They can detect AFib when it happens while you're wearing them under good conditions, but they can't guarantee you don't have a monitor you 24/7. They can't catch every episode. If your watch detects AFib, believe it. Go to a doctor immediately. Get it confirmed, get treated. But if your watch says you're fine, don't assume you are. If you have risk factors, age over 65, hypertension, diabetes, heart failure, obesity, sleep apnea. If you have symptoms, palpitations, lightheadedness, shortness of breath, get a proper workup. Holter monitor, 24 or 48 hours of continuous monitoring. Event monitor, a device you wear for weeks that records your rhythm continuously and transmits data. Implantable loop recorder, a small device implanted under your skin that monitors your rhythm for up to 3 years. These devices catch paroxysmal AFib that wearables miss. They provide continuous monitoring. They don't come off to charge. They don't shift when you move. They catch every episode, no matter how short, no matter when it happens. If you're relying on a wearable for a detection, understand its limitations. It's a useful tool, but it's not comprehensive. It's not foolproof. Don't let it give you false reassurance. The 7th myth, holiday heart. You drink alcohol and your heart goes into AFib. Wine, beer, liquor. You notice the pattern. After a night of drinking, your heart races, palpitations, maybe chest discomfort. You go to the emergency room. They catch you in AIB. They give you medications. You convert back to normal. Your doctor tells you it's holiday heart syndrome, alcohol-induced AFib. Just stop drinking and you'll be fine. You stop. You never drink again. You think the problem is solved. It's not. The alcohol didn't create your AIB. It unmasked it. The substrate was already there. The atrial fibrosis, the electrical remodeling, the vulnerable tissue. Your atria were a tinderbox waiting for a spark. Alcohol was the spark, but the tinderbox was already built. Here's what alcohol does. It affects your autonomic nervous system. It increases vagal tone, the parasympathetic nervous system. High vagal tone shortens the refractory period of atrial cells. This makes them more likely to fire erratically, more likely to start re-entry circuits, more likely to fibrillate. Alcohol also causes dehydration, electrolyte shifts, potassium and magnesium depletion. These shifts destabilize cardiac membranes. They make arrhythmias more likely, and alcohol is directly toxic to atrial tissue. Chronic heavy drinking causes atrial dilation, stretching, fibrosis. This creates the substrate for AFib even in people who didn't have it before. But here's the critical point. If you get AFib from alcohol, even once the substrate is there, you're not a normal person who drank too much. You're a person with vulnerable atria who drank enough to trigger them. And once the substrate exists, it doesn't go away, even if you never drink again. Other triggers can set off AFib, stress, sleep deprivation, caffeine, illness, dehydration, surgery. The substrate doesn't care what the trigger is, it only cares that a trigger occurred. David, 66, got AFib during his daughter's wedding. Open bar. He had 5 glasses of wine over the course of the evening, not drunk, just festive. Around midnight, his heart started racing, palpitations, chest tightness. He went to the ER. AFib with rapid ventricular response, heart rate 140. They gave him amitriptyl dilesum. His rate came down, but the rhythm didn't convert. They admitted him overnight. The next morning, he converted spontaneously back to sinus rhythm. His doctor said, "You had holiday heart, it's from the alcohol. Don't drink and you'll be fine." David never drank again, not a drop. 2 years later, he couldn't sleep. Work stress, a big project deadline. He was up until 3 a.m. working, tossing and turning when he finally got to bed. His heart went into AFib again. No alcohol, just stress and sleep deprivation. The same thing that happened with alcohol. The substrate was there, the trigger was different, but the result was the same. David's doctor started him on anticoagulation after the 2nd episode. His CHADS VASC score was 2, 1 point for age, 1 point for hypertension. His annual stroke risk was about 2.2% without anticoagulation. Anticoagulation was clearly indicated. But what about after the 1st episode? Should he have been anticoagulated then? Absolutely. Because the 1st episode of AFib, regardless of the trigger, tells you the substrate exists. The disease is there, and once it's there, it's permanent. This is why calling it holiday heart is misleading. It implies the AFib is situational, temporary, related only to alcohol. But that's not true. The AFib is permanent. The substrate is permanent. Alcohol just revealed it. And if you don't treat it as a chronic disease, if you just tell the patient to avoid alcohol and move on, you're setting them up for stroke. Because the next episode might not have an obvious trigger. It might be silent. It might last for weeks. And if the patient isn't anticoagulated, if they think they're fine because they stopped drinking, a clot can form, a stroke can happen. Holiday heart is a warning. It's your heart telling you the substrate exists. Don't ignore it. Treat it like the chronic disease it is. Anticoagulate, monitor, and yes, avoid alcohol. But don't think avoiding alcohol makes you safe. It doesn't. The disease is still there. The 8th and final myth, just a flutter. Your doctor did an EKG. He said you have atrial flutter, not atrial fibrillation. You felt relieved. Flutter sounds less serious than fibrillation. Surely the stroke risk is lower. Surely the treatment is less aggressive. It's not. Atrial flutter and atrial fibrillation are mechanically twins. The stroke risk is identical. The treatment is identical. Here's the difference. In atrial fibrillation, your atria quiver chaotically. There's no organized electrical pattern, hundreds of disorganized impulses firing from multiple locations, no coordinated contraction, just chaos. In atrial flutter, your atria beat rapidly. But in an organized pattern, there's a single re-entry circuit, usually in the right atrium. The electrical signal travels in a circle around an anatomical barrier, usually the tricuspid valve. This creates a regular rapid atrial rate, typically 250 to 300 beats per minute. The atrial activity looks different on an EKG. In AFib, you see irregular chaotic waves, no clear P waves, just fibrillatory waves. In flutter, you see regular saw-to-flutter waves, a consistent pattern. It looks more organized, and it is. But here's what doesn't change. The atria aren't contracting effectively. In flutter, the atria are beating 250 to 300 times per minute. That's too fast for effective mechanical contraction. The muscle doesn't have time to fill and empty properly. Blood still pools. The left atrial appendage is still stagnant. Clots still form. The mechanism is the same. Stasis, Verruce, triad, Fibrin Clots. the stroke risk is the same. Multiple studies have confirmed this. When you control for other risk factors, age, hypertension, diabetes, heart failure, patients with atrial flutter have the same stroke risk as patients with atrial fibrillation. The CHADS-2 VAS score applies equally to both rhythms. The anticoagulation guidelines are identical. If you have flutter with a CHADS-VASc score of 2 or higher, you need anticoagulation, same as AFib. And here's something most patients don't know. Flutter and AFib often coexist. They're two manifestations of the same substrate, the same atrial disease. Many patients have both. You might be in flutter today. Tomorrow, you'll be in AFib. Next week, back to flutter. They flip back and forth. This is because the substrate that creates flutter, the atrial fibrosis, the electrical remodeling, is the same substrate that creates AIB. If you have one, you're at high risk for the other. This is why the treatment is the same. Rate control or rhythm control, anticoagulation, ablation if needed. You treat flutter exactly like you treat AFib because mechanically, they're the same disease. Karen, 69, developed atrial flutter after cardiac surgery, coronary artery bypass grafting, postoperative day 3. Her heart went into flutter, atrial rate 280, ventricular rate 140. She felt terrible, palpitations, shortness of breath, dizziness. Her surgeon said it was common after cardiac surgery, probably temporary. They gave her amitriptyl. Her ventricular rate came down to 70. She felt better. Her surgeon said they'd monitor the flutter, see if it converted on its own. He didn't start anticoagulation. He said it was probably just post-op inflammation. It would resolve. Karen went home 2 days later, still in flutter, still not anticoagulated. 3 weeks later, she had a stroke, right-sided weakness, facial droop, expressive aphasia, massive left MCA stroke. At the hospital, they did a transesophageal echo, large clot in the left atrial appendage. The clot had formed during those 3 weeks of untreated flutter. It embolized, blocked her middle cerebral artery, destroyed a third of her left hemisphere. Karen survived, but she never recovered. She couldn't speak. She couldn't use her right arm or leg. She went to a nursing home. She lived there for 2 years before dying of aspiration pneumonia, all because someone thought flutter was safer than AFib. It's not. The stroke risk is identical. The treatment should be identical. If you have atrial flutter, demand the same treatment you'd get for AFib, anticoagulation, rate control, or rhythm control monitoring. Don't let the name fool you. Don't let the more organized appearance on the EKG fool you. Mechanically, flutter is AFib. Treat it that way. Protect yourself. We've covered all 8 myths: the aspirin myth, the silent myth, the rate control myth, the fall risk myth, the I'm cured myth, the watch myth, the holiday heart myth, the flutter myth. Each one is dangerous. Each one can lead to stroke. Each one is believed by millions of people right now. Maybe you believed some of them. Maybe your doctor told you some of them. Maybe you're making decisions based on these myths right now. Stop today, right now, because the truth is this: AFib is a stroke disease. Everything else is secondary. The palpitations, the fatigue, the shortness of breath, those are just symptoms. They're uncomfortable, but they won't kill you. Stroke will kill you. Or worse, it will leave you alive but destroyed, paralyzed, unable to speak, unable to think clearly, unable to care for yourself, dependent in a nursing home. That's the real danger of AFib, not the palpitations, the stroke. And the only proven way to prevent AFib stroke is anticoagulation, not aspirin, not rate control, not avoiding alcohol, not trusting your watch. Anticoagulation. Waririn, Aixaban, Rivaroxaban, Dagatran, Edoxaban. These medications prevent fibrin clots. They keep your left atrial appendage from forming the clot that will destroy your brain. And unless you have a true contraindication, active bleeding, recent intracranial hemorrhage, you should be on one. No excuses, no myths, no fear, just protection. Now, I need you to do 4 things. First, comment below. Tell me which myth you believed. Tell me if your doctor told you any of these myths. Were you told aspirin was enough? Were you told to stop anticoagulation after an ablation? Were you told you're too old for blood thinners because you might fall? Comment your story because your experience helps others. When people read your comment, they realize they're not alone. They realize their doctor might be wrong, and that realization could save their life. Comment now. Second, share this video. Send it to everyone you know with AFib, your parents, your spouse, your friends, anyone who's been diagnosed. Text it, email it, post it on Facebook. Because somewhere right now, someone with AFib is taking aspirin thinking they're protected. Someone stopped their blood thinner after cardioversion. Someone refused anticoagulation because they're afraid of bleeding. This video could save them from a stroke. Share it now. Third, join Senior Health Life Daily. That's my community where I share medical protocols your doctor doesn't teach. I've created a comprehensive ebook specifically about AFib. It's called the AFib Stroke Prevention Protocol. This isn't free. This is a premium resource that I've spent months creating. It covers everything you need to know. The complete science of AFib clot formation. Why fibrin clots are different from platelet clots. The detailed pathophysiology of the left atrial appendage. How to calculate your actual stroke risk using Chad's VASC score. Which anticoagulant is right for you? The pros and cons of Warren versus the newer agents. How to manage bleeding risk without refusing anticoagulation. What to do if you fall while on blood thinners. When to go to the ER and when to just monitor. The truth about dietary restrictions on Warren. The foods that interact and the foods that don't. When ablation is appropriate and when it's not. The success rates, the risks, the alternatives. How to reduce your AIB burden through lifestyle, weight loss, sleep apnea treatment, blood pressure control, alcohol avoidance, the supplements that might help, magnesium, fish oil, CoQ10, the evidence for each, the doses, the interactions, warning signs of stroke, the symptoms you cannot ignore, what to do in the first minutes, how to prevent permanent damage, real case studies, patients who prevented strokes, patients who didn't, what they did right, what they did wrong. To get this ebook, go to the link in the description. Join Senior Health Life Daily. This is an investment in your health, in your brain, in your future. It's worth far more than the small price I'm charging. Click the link, get the ebook, get the knowledge that could save your life. Fourth, watch one more video before you leave. Click the link appearing on your screen right now. It's called the one blood thinner mistake that causes strokes even when you're taking it. Because even if you're on anticoagulation, even if you're doing everything I've told you today, there's one common mistake that renders your blood thinner useless. One drug interaction, one food timing error, one supplement that blocks its effect. You need to know what it is. Click now, watch that video, make sure you're not making this critical error, and subscribe to this channel if you haven't already. Hit that subscribe button right now because I'm committed to giving you the truth about cardiovascular disease, the mechanisms your doctor doesn't explain, the myths that are killing people, the protocols that actually work, not what's convenient, not what insurance companies prefer, not what's easiest, the truth. Subscribe so you don't miss it. Take care of your heart. If you have AIB, get on anticoagulation. Don't believe the myths. Don't let fear control your decisions. Don't wait until it's too late. The stroke doesn't give you a warning. The stroke doesn't give you a second chance. It just destroys you. Protect yourself now. Get on anticoagulation. Stay on anticoagulation. Monitor your rhythm. Work with your doctor. And if your doctor tells you any of these myths, show them this video. Show them the data. Demand better care. Your brain depends on it. That's all for today. I'll see you in the next video.